Thanks very much. And thanks again also to the organizers for asking me to come back this year. I also should mention that my disclosures didn't make it onto the slide deck, but it is in the book somewhere, and I will say I have some, and I wish I had more. I want to start out with the statistics from the U.S. on cancer, just to remind you that when you think about the big four, breast cancer, colorectal cancer, lung cancer, and prostate cancer, the age-adjusted mortality rates are dropping dramatically. That's a real tribute to all of you and to everyone who's worked so hard in these diseases and invested in better treatments or prevention for these diseases. But we have not had that experience in pancreatic cancer yet. The incidence continues to rise, and we haven't had the impact in our treatments on this disease, nor do we have an impact in early detection. So as of this year, pancreatic cancer deaths in the U.S. exceeded breast cancer deaths. And that should be a big wake-up call to all of us and to policymakers and those that invest in this, in research in this disease, to see if we can do more. And I just said that. So this is a tough disease. I don't need to reiterate all of the basics about it, but just to remind you that most of the patients are diagnosed with advanced unresectable or metastatic disease. If you've heard already, if you have surgery and adjuvant therapy, 80% of those patients will still relapse. Our cure rate is creeping up a tiny bit, but it's only at 7%, close to 8%. That's not nearly good enough for any of us. And for patients who present with metastatic disease who are not able to receive treatment, the median survival is only about 3 months. Believe me, this is the Mount Everest of all epithelial cancers. I need help advancing. Jude, thanks. We don't know why the disease is so aggressive. We know that there are no really early defining symptoms. We need to work on that. We also know, based on our clinical knowledge as well as preclinical models, that we can have very early invasion and metastases in some patients. And for that subset of patients, early diagnosis may not matter. We know the disease is somewhat chemo-resistant, but as you've heard from Eileen, this is changing. And we know these patients are not as fit. One of the reasons they may not be as fit is that they're trying to survive in a virtual sea of disabling cytokines. So we really have our work cut out for us when we're designing trials for these patients and just treating these patients even on a conventional level. We know quite a bit about the biology of this disease, and I use this cartoon from our own group, Matthias Hebrock, who has defined really that the acinar cell is probably the cell of origin for this disease. In the presence of activated KRAS, the acinar cells undergo acinar to ductal metaplasia. In fact, they look like a duct cell, but it really started as an acinar cell. And as you have increasing dysplasia, which we call pannin, we know what the molecular events that occur with that oncogenic development. And much of this work was done in terms of identifying the mutational pattern, was done through the elegant work at Johns Hopkins. What this cartoon also shows you is that the desmoplasia that is so characteristic in this disease really does increase along with pannin development. And that's a very important part of our understanding of the biology, as you heard from Gianpaolo, that we really are needing to understand and have begun to understand more about the microenvironment that supports this malignancy. Now I want to talk a little bit about diversity in this disease, and very elegant work done by Christine Iacobuzzi-O'Donoghue when she was still at Johns Hopkins in her warm autopsy series really show that there were 2 clinical manifestations of this disease. Those of us who treat these patients suspected this, but Christine actually proved it. By looking at the autopsy, she was able to define patients who really had a major pattern of locally destructive disease with either no or at least oligometastatic disease, and then a separate clinical pattern in which patients had disease that was confined to the pancreas but actually had wildly mega-metastatic disease. Then we can look on a molecular level and we see diversity as well. This was the first attempt at subclassifying these tumors done by Eric Collison in our group, in which he defined 3 classes, 2 of which we thought had biological importance, the quasi-mesenchymal and the classical subtypes. These have different outcomes clinically, these 2 subtypes, and even on terms of treatment using cell lines that were characterized. Eric was able to show that the mesenchymal subclass was the type the cell type that seemed to respond to gemcitabine, whereas the classical seemed to respond to erlotinib. So really it's increasingly clear to us that this is not just one disease, that there are different clinical patterns, there are different molecular patterns, and we need to begin to respect that and figure out how to manage patients with more precision. Now, we are moving in, I think, to an era in which we are going to be able to identify certain biomarkers that will help us subclass and treat patients on an individual level. However, as I stand before you today, I cannot tell you that there is a validated biomarker for treatment selection, and you've heard from Eileen about one effort, but there are many that may help us in the future when we're selecting just a common treatment. Now, this is actually a well-traveled cartoon. Eileen had a similar one in her slide deck, but just showing you the evolution of therapies over time. And she went into great detail about these 2 regimens, FOLFIRINOX and gemcitabine and nab-paclitaxel. And I agree with her entirely on every point she made. The first point is that you can't compare these because they were 2 different populations. The second point is really that selecting treatment for these patients is all about patient preference. It's all about the existing comorbidities. I don't look at this as a contest, frankly. I'm really happy we have 2 active regimens in this disease. I have 2 regimens to choose from to stabilize my patients so that they can try new things. And so I think this is a really, really important thing, and we really don't want to discard either one of these treatments for excessive toxicity or slightly less activity. We really want to build on both of them. Now, she mentioned these other options that are in the NCCN guidelines, gemcitabine and capecitabine, gemcitabine and cisplatin, GTX, gemcitabine and erlotinib. There are reasons why you may wish to select one or of these regimens for a given patient. Gemcitabine and capecitabine, which showed improved progression-free survival in a study done a long time ago by David Cunningham, this is still pretty important, improved progression-free survival. And so for an older patient who might be able to handle something more than gemcitabine monotherapy, that might be a great choice. Gemcitabine and cisplatin remains in our guidelines for patients with mutations in DNA repair pathways. These patients tend to be exquisitely sensitive to cisplatin-based regimens. GTX, fixed dose rate gemcitabine, Taxotere, and capecitabine remains in our guidelines because it's a highly active regimen. It's just never been compared to gemcitabine monotherapy in a prospective randomized trial so that we don't know the degree of benefit. And then you've heard the story about erlotinib, something which is becoming less and less of a preferred option. So moving forward, I do believe that we need to build on both these regimens. And as I mentioned, giving special consideration to gemcitabine and cisplatin in selected individuals. When you look, and this was a snapshot I took maybe a few months ago, I looked into clinicaltrials.gov just to see how many trials were using which chemotherapy regimen as a backbone. And in fact, there was only one trial, and it's a publicly sponsored trial, a randomized trial with PEG-PH20, a hyaluronidase, which I'll mention more about in a minute. But there was only one publicly sponsored randomized trial with FOLFIRINOX, and all of the other randomized trials are using gemcitabine and nab-paclitaxel. And I suspect that many companies, when they have no other reason to combine with a given agent, will choose gemcitabine and nab-paclitaxel because of the fact that it is an established FDA-approved regimen and perhaps easier from a regulatory pathway. If you look at all 54 open trials, phase 1 through phase 3, there were only 2 trials that incorporated FOLFIRINOX. Now, I want to build a little bit on what Eileen mentioned in terms of maintenance. In terms of new strategies, I think we need to think about maintenance strategies. If we have stabilizing chemotherapy, we want to be able to keep those patients healthy and progression-free for as long as possible. She mentioned this particular trial, Mikhail Rainey and his group, they took patients who had been treated with a variety of regimens. When they had good disease control, they randomized them to sunitinib or to observation. And you can see that there was a powerful benefit of a drug that we have more or less discarded, or a class of drugs we've discarded in this disease. So there may be a difference in when you apply an anti-angiogenic regimen in this disease setting. So perhaps after treatment, when there is perhaps some stromal remodeling and some changes in the microenvironment, an anti-angiogenic agent might be very, very useful. And I think we need to take an important lesson from Rainey and his group from this particular effort. Our group is involved with a major Stand Up to Cancer effort in which we're looking at maintenance with a vaccine plus a checkpoint inhibitor, ipilimumab, versus continued chemotherapy. So patients who have received maximum benefit with FOLFIRINOX are then offered a randomized trial in which they would continue on a fluorinated pyrimidine, that is capecitabine, versus the vaccine plus IPI. And then the POLO1 that Eileen also mentioned, I think, is a very important effort in patients who have known BRCA or PALB2 mutations, those patients who, again, who have received maximum benefit on a first-line platinum regimen, are offered the opportunity to go on olaparib or placebo. Now, I'd like to move into something that is a new effort in the US, and I have permission from the Pancreatic Cancer Action Network to talk about this. This is an effort called Precision Promise, and it's going to be a major effort in the US. There will be a parallel effort in the UK, and I hope that this will be extended to and networked with other larger efforts around the world. Basically, the idea behind Precision Promise is to transform outcomes for all patients through a very flexible research and clinical trials platform. And this is a very transparent effort, and it's a collaborative effort that is going to involve very striking public and private partnerships. It's very patient-centric as well. Again, the guiding principles, it's patient-centric, it's big. We are, because of the rising incidence and the lack of our ability to change the statistics, we feel a sense of urgency in getting this done. And we really need to interface what we know from our scientific discovery with the patient experience as much as possible throughout a patient's journey. And we hope we'll be able to sustain this effort through funding from a variety of sources. The network will have a coordinating center that involves an executive committee, working groups around various types of clinical trial targets, and a lot of infrastructure for communication and information exchange. Initially, we will network 10 centers in the United States, and our hope is to grow this way beyond that. And then we will have research grants that are focused on small, rapid-fire clinical trials that will give us signals that will help decide whether to take something into more development. This will be a master protocol with a number of sub-studies that are molecularly stratified. Again, these are signal-seeking studies, adaptive designs, very flexible, very rapid pace. This shows you what we will be offering to patients who enroll onto the master protocol. They will have a biopsy, and part of the biopsy will go for genomic sequencing and transcriptome sequencing. The other part will be obviously for diagnostic purposes and for immunohistochemistry starting out with hyaluronic acid and a number of immunotherapy markers, and there will be others as we develop our list. This is still very much a work in progress, and we're meeting almost monthly to work on the evolution of this. This would be the general concept for the trial design. If a patient had high hyaluronic acid, then in the tumor, then there would be an effort to match that patient with either the current HALO 301 trial, or to identify within the master protocol a sub-study that for patients who couldn't have access to that trial would have an ability to participate in. We will then move to our next step with DNA deficient repair patients who I'll mention in a minute how we might manage those. And then we will have patients for who we may find a marker, but we do not have an available sub-study. In that case, we will try to match that patient with the MATCH trial, which is an NCI effort providing drug for selected targets, or the TAPER trial, which is an ASCO effort with 17 drugs for 17 different targets. Now, just to mention a little bit about hyaluronic acid, I'm sure you're aware of the initial trial with PEG-PH20, which is a pegylated hyaluronidase. Hyaluronic acid really is a barrier to access to drugs, and in preclinical models, depleting hyaluronan improved drug access and improved therapeutic outcome. In the initial trial that was done by Halozyme, in the high HA patients, there was seen an improved survival with PEG-PH20 combined with gemcitabine and nab-paclitaxel compared to gemcitabine and nab-paclitaxel alone. And that has led now to a large randomized trial in which it will be a registration trial, which is now ongoing. And this is PEG-PH20 with gemcitabine and nab-paclitaxel versus the chemotherapy combination alone. If you think about the other subsets of DNA repair, obviously we have the classic ones that we deal with all the time, the patients with BRCA mutation or PALB2 mutation. And Eileen O'Reilly is already conducting a trial which is answering a question up front about the relative value of cisplatin and gemcitabine with or without olaparib. This is a multi-site trial, and this is obviously going to be very informative for patients with germline inherited defects. But there is a larger group, and you saw this from Gianpaolo, that if you look at a whole ICGC cohort, about 24% of the patients were BRCA-like in the sense that they had some defect that would perhaps be able to put those patients into that classification. So one sub-study that will be in the Precision Promise will be a sub-study around this particular patient population. And while we haven't decided exactly what that study will look like, clearly we will try to build on the fact that this may be the Achilles heel for this particular group. Now, you heard Gianpaolo mention the effectiveness of Pembrolizumab in MSI-high patients, and there has been a very, very small effort. Only 1% of pancreatic adenocarcinomas are MSI-high, but out of the 4 patients that were studied in this particular trial that was conducted through the work of Young Lee at Hopkins, of those 4 patients, 2 had very dramatic responses. So there's every reason to believe that when we find that rare patient, that we should connect them with a trial that involves Pembrolizumab. Now, we can take this even further than some of the things that we think about in terms of novel targets. We can think about trials that are being run right now in subsets. And one is the MM141 trial. Andrew Cohen, my group, is helping to lead this trial. This particular entity is a bispecific antibody that recognizes IGF-1R and HER3. The trial is being conducted in a subset of patients with high IGF-1 in the serum or plasma. And so one might even be thinking about adding, in Precision Promise, plasma analysis of IGF-1 to help understand whether a patient might be eligible for that particular trial. This is the design of that trial, the antibody, again, on the backbone of gemcitabine and nab-paclitaxel. Now, we want, in this Precision Promise, everybody to play. And so while I've just talked about small subsets, we will have a large group of patients who do not have an obvious target to go after. That's a perfect setting in which to steer those patients into an immunotherapy trial. And considering genetic heterogeneity in all of our cancers, adaptive immunity may actually be our best asset. And we're certainly seeing some really tremendous outcomes of checkpoint inhibitors in other diseases. But this doesn't really work in pancreatic ductal adenocarcinoma because this disease is not enriched with CD8 positive T cells, so the standard approaches with checkpoint inhibitors won't work and hasn't worked. So we have to do something different.
So Margaret,
yes,
we're kind of coming towards
I'm almost at the end.
Okay.
So that just leads me to our Stand Up to Cancer collaboration. We're working very hard and closely with Precision Promise to take some of our ideas into Precision Promise so that we can actually offer a menu of immunotherapy trials within that framework. Right now, we're targeting BTK, CD47, CD40, CXCR4, and we are also studying a vaccine with a checkpoint inhibitor. So these are all trials in progress. I can't tell you anything about outcome yet. We also have preclinical studies that are teeing us up for the next wave. So in summary, I think it's pretty exciting that we have stabilizing chemotherapy. I didn't discuss a major initiative in the US that's ongoing called the RAS Initiative to identify drugs that can inactivate activated RAS. Some of these are ready for clinical development, and that is going to be a very exciting effort. We now do have at least two, I should say, biomarker-driven trials in progress, and so that's a major step forward for us, just the fact that we're getting there. Precision Promise will launch next year. I think we're seeing stromal-associated targets thoroughly addressed, and I think that we should be doing window of opportunity trials, not only in the maintenance setting after successful chemotherapy, but also in the neoadjuvant setting. Thank you very much for your attention.